Reproductive pathology, ovarian tumors. All right, so for the ovarian tumors, what you first need to understand is the presentation of the patient. Now, this can be very confusing. We're going to break it down, but first and foremost, let's understand the presentation. So the most common presentation is going to be an adnexal mass, all right? So essentially an ovarian mass. It's going to present with abdominal distension and fullness, and it could have like bulk symptoms, meaning that like you feel like it bulky in your stomach or in your abdomen. You could get bowel obstruction because it can like compress on the bowel, and you can also see pleural effusion, all right? Now, what are the risk factors? Well, you have an increased risk of ovarian tumors with advanced age and increased number of lifetime ovulations, okay? So what does that mean? That means that patients that have multiple pregnancies have a decreased risk of ovarian tumors. And let's think about it this way. During pregnancy, you have 9 months without ovulation, okay? And so that's protective. You're not constantly using the epithelium and the germ cells and our sex cord stromal tumor, like all that stuff isn't going to be used consistently because you're giving yourself, your ovaries, a break for 9 months. So that's why having a pregnancy is protective against ovarian tumors. Also, OCPs, as we'll see later, is also protective against having tumors because when you are taking any OCPs, you no longer have menses. And when you don't have menses, you're not ovulating. Hence, it's protective because you're not using all the epithelium, you're not using your germ cells and all that stuff, okay? So very important. Now, moving on. There's 3 types of tumors. There's epithelial tumors, there's germ cell tumors, and there's sex cord stromal tumors. And we're going to differentiate them each by the way that they are. So the first one is epithelial tumors. The way that we can measure epithelial ovarian tumors is by CA-125 levels. All right, so keep that in the back of your mind because you need to know a lot of the cancer markers, and the one cancer marker for ovarian tumors that you need to know is CA-125. All right? Now, you have to understand for epithelial ovarian tumors, once again, it can be caused by, or it can cause an increased risk because of the increased number of ovulations. So once again, OCPs or multiply is going to lead to a decreased risk of ovarian tumors, especially epithelial, because you're not using the epithelium a lot. Now, there's multiple types, but the ones that we need to focus in on are here. Brenner's tumor. Brenner's tumor is usually benign, and it's bladder-like, okay? Bladder-like epithelium that's going to be seen on the ovary, and it has coffee bean nuclei, all right? Next is serous carcinoma. Serous carcinoma is the most common malignant ovarian neoplasm, and there's Samoa bodies. Lastly is the mucinous carcinoma, and it's rare, but it's malignant, and it may metastasize from the appendix or other GI tumors. And it can lead to pseudomyxoma peritoneum, which is just intraperitoneal accumulation of mucinous material. So you'll have just like mucus building up in your peritoneum, all right? Those are the 3 most important things that you have to know, all right? Now, if you see epithelial tumors, it's usually going to be a postmenopausal woman about 60 to 70 years old, all right? But that's not like a quick way to differentiate, but it's just something that you can like look at to help you in the vignette. Next is germ cell tumors. Germ cell tumors are going to be your only ovarian tumors that you're going to see in a young woman that's about 10 to 30 years old, okay? Now, the most common is a teratoma, mature cystic teratoma, okay? It's benign, and it's the most common, once again, in young females, and they have all 3 germ layers. This is going to be really, really easy for you to see because it has all 3 germ layers. It's very creepy. The teratomas can have teeth, hair, sebum, all right? Now, because it's most common, it can cause the increased risk of ovarian torsion depending on the size, right? Anything that's greater than or equal to 5 centimeters can increase your risk for ovarian torsion. Now, it could also have thyroid tissue involved in it because it has all 3 germ layers in it. So teratoma can have thyroid tissue present, and that's known as struma ovarii. And you have to take a look at both what the teratoma looks like in general, in gross anatomy, and then what the struma ovarii looks like on histology, okay? But that's really all you need to know, all right? Next, for the germ cell tumor, is going to be dysgerminoma. What you need to know about dysgerminoma is that the tumor markers are increased LDH as well as increased HCG. Okay, and it's equivalent to a male seminoma. Easy, right? Straightforward. Lastly is the yolk sac tumor, the last germ cell tumor, and the marker is AFP. You have Schiller-Duval bodies that are seen on histology, and it's usually seen within children. Okay, so overall, the germ cell tumors you need to know are teratoma that has all 3 germ layers. It's the creepy one with teeth, hair, and a bunch of other stuff. Could be thyroid, right? Dysgerminoma has LDH and HCG as their tumor markers. And yolk sac tumor has Schiller-Duval, AFP as its tumor marker, and it's seen in children. Lastly are the sex cord stromal tumors. These tumors, the way that I differentiate them is that they produce hormones of some type. So the first one is the fibroma. Fibroma is benign, and it's like a bundle of spindle-shaped fibroblasts. And you can see Meags syndrome. Meags syndrome is relatively lower yield, but it's just something worth mentioning. It's a triad of ovarian fibroma, and then you get ascites and pleural effusion. Okay? So if you see pleural effusion, start thinking about fibromas. All right, I'm going to skip thecoma because it's relatively lower yield. Next is the Sertoli Leydig cell tumor. Sertoli and Leydig cells are normally seen in males, right? So if we have Sertoli Leydig cell tumors in females, then you know that they can potentially produce androgens and it can cause virilization. So if virilization occurs, we know that we could be potentially dealing with a sex cord stromal tumor, specifically the Sertoli Leydig cell tumor, and they get virilization because of the increase in androgens. Lastly, and most importantly in high yield, is our granulosa cell tumor. The granulosa cell tumor is the most common malignant sex cord stromal tumor. You have to know it. It produces estrogen and progesterone, all right? And what they love to ask is essentially, what do we see as a tumor marker, one, and what do we see on histology? Histology shows Calla-Exner bodies, all right? Very important. You have to know Calla-Exner bodies. And the tumor marker is going to be increase in inhibin. Increase in inhibin makes sense because we have now a granulosa cell tumor. That means there's more granulosa cells than anything else. And we do know that granulosa cells also produce inhibin in order to inhibit FSH. So more granulosa cells means more inhibin. So that's why the tumor marker is going to be increase in inhibin. All right. So that's all of our ovarian tumors. Keep in mind the CA125 tumor marker to help us differentiate. The adnexal masses can lead to the adnexal torsion. And then we have epithelial cell tumors, which is going to be our Brenner, serous, and mucinous. Our germ cell tumors, which is teratoma, dysgerminoma, and yolk sac tumors. And then our sex cord stromal tumors, which is our fibromas, Sertoli Leydig cell tumor, and most importantly, the granulosa cell tumor. That's all for ovarian tumors, and we'll be going on to uterine pathologies next.